that snow that we were having yesterday. Otherwise, I'd have to start singing a song, oh, the weather outside is frightful, inside is so delightful. But fortunately, I won't be singing, so you're lucky. I'm Wayne Tuckson. I have the pleasure of being the moderator for this program. And the title of the program is Screening to Treatment. Healing Starts with My Advocacy. So with that in mind, why are you here today? Anybody, come on. Why are you here today? You, fancy hair. Yes, ma'am. You. That's right. That's what you get for making eye contact. That'll teach you. To get educated. All right. Young lady behind her wearing the skull cap with the red and everything on there. Why'd you come out here today? More in the community. All right. Sister with the loved skull cap on. Why'd you come out here today? What do you want? What do you want to get out of this meeting? Prevention. That's great. That's the whole idea. And that's what we're going to try to do today. Yes, sir. Please.
To learn more about the services that are offered pertaining to different health services.
Okay, that's very good. So the main thing is, how do we do something that's going to keep us alive? Not only alive, but with a good quality of life. Because, we all want to live long, but we want to live long with a good quality. And we also want our families to live long with a good quality. And there's some things that we can do. Yes, there are a lot of external forces that are acting upon us. Some we can do, some we can't. But there are a lot of things that we ourselves can do. And that's the whole idea here today, is to talk about those things that we can do. So the first thing I want to make sure of is that in the pamphlets, which have a lot of information, there is a survey form. Please, it says pre-survey. Fill that out. On the back is a post-survey. Don't fill that one out yet. Though you can put down excellent and all that sort of thing if you want to. But we want to wait till after the program before you do that. But do please fill out the program, the pre-survey program. To get things started, we're going to have a welcome and prayer from Reverend Tanya Triplett. She's the Director of Discipleship and Congregational Engagement here at Burnett Avenue Baptist Church.
Good morning to everyone. First of all, I'd like to welcome everyone that is here and participating, all of our vendors and everyone that's collaborating with us, the Health Collaborative, Amgen, and also to our own, our Journey of Hope. Our nickname for them is OJO. Here at Burnett Avenue, and they have helped and ministered tremendously to members of our church and in the community. And for everyone that's here and all of our vendors, we thank you for coming and sharing with us. May we be more equipped and more knowledgeable of what we need to do once we leave here today. Let us pray. Gracious Father, I bless you and praise you. Thank you so much for this opportunity to come together and learn, dear Heavenly Father. We first of all want to thank you for the gifts that you have given to all of the persons that are participating today, all of the speakers, the collaboratives that are taking place, God. You have touched and given them the talents of medicine, of research, of knowledge, of learning, God. And yes, you are our ultimate healer, but you also share that healing power with others, God, to equip them so they can equip us. Bless this gathering together today. May we be more knowledgeable. May we open our minds to thoughts of prevention, things that we can do to help better our lives, because we want to do the best we can to continue to live for you. We thank you for each and every person here in their households, and we pray whatever their needs are, that you would grant them like only you can. It's in Jesus' name we pray. Amen. And thank you again so much on behalf of our pastor, Pastor Corey Schul, and our entire Burnett family. We thank you for coming today and participating. Amen. God bless.
Thank you very much. And by the way, Reverend Triplett, this is a beautiful facility that you all have out here, and I want to thank you very much for hosting this program. We look forward to a wonderful, wonderful presentation. Next, I'd like to bring up Mr. Stan Watson. Deacon Watson is a former Georgia state legislator, so don't blame him. He's former. Don't blame him for any of that crazy stuff coming out of Georgia right now. He is the National Director of Faith-Based Initiatives with the HEAL Collaborative.
Good morning. Let me just say I apologize because I had to ride with Dr. Tuckson this morning, so I apologize for having to ride with him this morning. But I'm glad to be here this morning. My name is Stan Watson. I'm the National Director for Faith-Based Initiatives and also for Policy for HEAL. of Atlanta, Georgia. We're so happy that Burnett Avenue was able to host this for us today. On behalf of our sponsor, Amgen, and the Hill Collaborative from Atlanta, we thank you for allowing us to be here in your community this morning. We have an array of speakers that are professional. We have an august body of a platform for you to reserve your thoughts and mind today for lung cancer. So we only ask two things. As Dr. Tuxton said, we want you to fill out the pre-survey for us today, and then do the other survey at the end of the program. And then lastly, we hope that you open up the windows of your mind today, that you may be able to absorb all the information that our speakers are going to present for you today. So again, thank you, Pastor. We thank you, Burnett Avenue Church, for hosting us today. And again, on behalf of our board of directors from Hill Collaborative Atlanta, thank you for having us, and we look for a great time. Have a great morning.
Thank you very much, Mr. Watson. You know, when doing programs like this, it's a collaborative effort. This is the community coming together. If you notice, you got the Kentucky Cancer Program in the personage of Virginia Bradford. You have organizations like Heartland Imaging who are here to take in what we're doing, because they're the people that are going to help us as far as getting the imaging studies done. You have groups like HEAL, but then you also have pharmaceutical companies such as Amgen. And it's amazing when you think that a billion-dollar industry has taken it upon themselves to be interested, invested in our well-being, that they're going to participate and set up programs like this. And I don't think you really appreciate it. This is not the usual course of events when companies like this do get involved in the community level. Yeah, at talking to hospital chains and insurance companies, yes. But coming down and talking to us, this is a little different, and I really appreciate the effort on the part of Amgen. And to give us some words, we have Mr. Gregory Watties, who is the Oncology Portfolio Manager from Amgen. Now, you got to be careful with him. He's going to speak a little slow because he's from Indianapolis, so give the brother a break, all right?
Good morning, everybody. I'm just going to read a little bit, actually a few words for you. First, good morning, and as he said, my name's Greg Watties. I'm the Oncology Key Account Manager from Amgen that covers Indiana and Kentucky, so I do cover Kentucky. And I'm really excited to be here today representing Amgen as we support the amazing work that's being done by Heal Collaborative. At Amgen, we're all about helping people live better lives and healthier lives. As a global biotechnology company, we're focused on creating and delivering innovative treatments for serious illnesses, but our mission goes beyond that. We're committed to making positive impact on the world and ensuring that everyone, no matter what their background, has access to the care that they need. I think that's really important. Everybody gets access to the care they need. Health equity is something also we take seriously. That's why we're proud to back the initiatives like the workshop today and the partnership with Heal Collaborative. Whether it's expanding access to clinical trials, educating communities, or working towards inclusive and accessible healthcare, at Amgen, we're all in. Events like this one are important steps in finding solutions and making real progress towards better healthcare for everyone. Thank you for being here today. It's inspiring to see so many people come together to learn about lung cancer. This is the first step to becoming a better educated and empowered advocate for yourself and others. A huge thank you, a really big thank you to Heal Collaborative for putting this event together. I know it's going to be a great discussion and hopefully a springboard for meaningful action. So thanks again for being a part of this important discussion, and I can't wait to get started.
Thank you very much.
Yes, sir.
In the beginning, I asked a few questions, and people talked about prevention and looking at things we can do as far as treating things as far as lung cancer is concerned. I think prevention is a key thing. You know, if we can prevent the development of something, you don't have to worry about treating it, to me, which is the greatest thing in the world. You save money and you save people's lives. Prevention, 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 that's the way to go. But sometimes you can't prevent. And if we can't prevent something, we want to diagnose it early. Why? Because the earlier you make a diagnosis, the easier it is to treat somebody. We don't want to diagnose it when it's real late, and then you get treatment, it gets very complicated. To try to set the stage for us as far as what's going on as far as lung cancer, and by the way, if you want to know what your lungs look like, they're out there in the lobby. I just sure am glad this isn't a conference on prostate cancer. But anyway, but if you haven't had a chance to take a good look at the lungs, do take a look at it. But our first speaker, to try to get things going for us, is going to set that stage for us. I want to remind you that at the end of all of the presentations, we're going to have a question and answer. So as you hear our speakers give their presentations, please make notes to yourself if you have a question or something you want us to make sure we come back and cover. So our first speaker is Dr. Eric Flanow. Dr. Flanow is Associate Professor, Department of Medicine at the Morehouse School of Medicine in Atlanta, Georgia. He's also Chief and Director of the Pulmonary and Critical Care and Interventional Pulmonary Medicine at Grady Hospital, Morehouse School of Medicine. Dr. Flanow is several papers, speaks all over the country, and it's always a pleasure to have him talk to us about lung cancer, prevalence, disparity, screening, treatment, and myths about alternatives to tobacco. Dr. Flanow, thank you, sir.
I'm going to take this down if it's okay. So I've been tasked with trying to get you through all about lung cancer. They tell me about 20 minutes in the past, and then I run over and they say 25 and then 30. So I got a short period of time to get you through everything from beginning to end and give you a general understanding. If there's things that don't make sense, let me know, or when doing question and answer, we can go through it. Next slide. But what I want to do is give you an idea of exactly what is lung cancer, because I think there's a lot of misconceptions about what cancer is. Next slide. So this is specifically lung cancer, but if we talk about cancer in general, all cancer is that you just have this may not show up there, you just have a normal cell, and then what happens in the normal cell is it goes through some genetic change. And what that genetic change does is it starts to cause that cell to go cancerous, and it just makes it divide. So you go from 1 cell to 2 cells to 4 cells to where it starts taking over other parts of the body, and that's what. It could be a breast cell, it could be a prostate cell, it could be a colon cell. For this talk, we're going to talk about lung cancer. So that's all it is. These mutations cause the cells to grow out of control and take over other parts of the body. Next slide. Okay. When we think about lung cancer, there's 2 main types you're going to hear about, okay? One is going to be small cell. And if you look over here on the left-hand side, you'll see the blue, those are actually the cells. Each little purple dot, that's one of the cells, okay? So they're really small. These grow extremely fast, okay? And with respect to a causative agent, there's a higher link to cancer, to smoking with this small cell cancer. Now, I'm gonna, there's a lot of, talk lately about, it's not a smoking-related cancer or whatever else. We're just gonna use smoking as a risk factor for developing cancer, okay? And it's because it's so fast-growing and it spreads fast-growing and fast-spreading. There's 2 main stages that we think about. It's either a limited stage where it's limited to only part of the body, the lung part, or it's extensive where it's gotten to other parts of the body, okay? On the other side, there is, us doctors are not really good at naming things, non-small cell. But if you look at it, you can see the cells are larger, okay? These grow a little bit slower, okay, because they're large, they have to grow a bit larger. There's more links to the causes of that, and we'll talk about some of those. And then the stages, we talk about local, regional, distance, or sometimes you might hear staging where they say 1, 2, 3, 4. It's just basic. If it's local, it's in one spot. If it's regional, it may be in one spot in the lung and the lymph nodes. And if it's distant, it's gone to other parts of the body. Next slide. So when you think about lung cancer causes, I don't want you to think as one specific thing is causing in general. You need to think of it as increasing the risk factors for developing lung cancer. And number 1 in the United States, and either whether it's small cell or non-small cell, is smoking, okay? Has the highest link to it. So that is a risk factor for developing it, okay? Number 2 is radon. How many of you have heard of radon before? Okay, so a lot of hands up, so you're pretty well at the. So for those that haven't heard of radon, radon is a breakdown product of uranium. It's in the soil, comes out of some granite and whatever else. It has no smell, it has no color, it has no taste, but it's radioactivity that can come up, and it can come into houses, into neighborhoods and whatever else, and that is a risk factor. And what we do know as we started paying attention to it is that there's about 36% of the test for radon done in houses here in Kentucky are above the EPA's recommended safety levels. That's almost 40% of the houses here have high levels of radon. And so when you see some of your numbers, you're going to realize why lung cancer is really a big problem here in Kentucky. And then there's other things you've heard about, asbestos and pollution. Now, asbestos, if you're sitting up late, you're going to watch a television show, you're going to hear about, the commercial comes on, oh, do you have mesothelioma? Were you exposed to asbestos? And I can tell you, if you were exposed to mesothelioma, let me get it straight. If you have mesothelioma, okay, and that means you were likely exposed to asbestos, a product and insulation used to use long ago. It gets in the lungs, it sits there, it causes cancer. However, if you were exposed to asbestos, okay, the most likely cancer you're going to get is lung cancer, okay? And then there's other chemicals, there's factories, and other types of pollution. But the thing that's really important is just having lungs can be a risk factor for developing lung cancer. So when we start talking about all these things, even if you haven't smoked, having lungs can get you a risk factor, can be a risk factor for developing lung cancer. So all of these things are additive. And not only additive, but they're multiplicative, right? So smoking increases you by like 10 times, and then being exposed to asbestos increases you by 6 times. So the two of those together increase you by 60 times the likelihood of developing lung cancer. So keep that in mind. Next slide. Okay. So why is lung cancer specifically bad for blacks? Next slide. Okay. So just give you a general idea, and I was talking about this, the new cases of lung cancer, this is across the 48 states that have actually turned in information about developing lung cancer. The new cases across the board, the number one state for developing new cases this year is Kentucky, right? So this is telling you something. When I show you your smoking rates there, you're going to say, hey, but something doesn't match up, and that's going to tell you a little bit more. Next slide. But specifically for African Americans, and we start talking about disparities, these differences between races and what else, we have to take a lot of things into consideration. And one is, I break it down to health and health care. And when we talk about health, we think about the environmental exposures you have, the biology, because we know not everybody's body behaves the same to different exposures, different risk factors. And so you have to take those in roles, how those contribute to your health, and then we have to look at the health care, whether that's the health care system and what's available, what's not available, where you have screening, where you have the tests, where you have the treatments available, and then the opportunity to detect early cancers, okay, especially with screening. Next slide. Okay. So if we look at the health versus the health care, we know that blacks have the highest death rates, despite smoking equally as other races, and sometimes less. So that tells you something. Blacks are less likely to receive any type of screening. They're diagnosed at later stages because of that, and they're less likely to have treatment for less likely to have rates of less likely to have treatment for any lung cancer. Next slide. Okay. So I'm going to show you a lot of numbers up here. I'm going to give you a general idea of what we're looking at, though. So on the top row, you're looking at the estimated new cancers of any type in the United States for African Americans, males and females. And if you look at for males, number one's prostate, okay? And you expect to see about 41,000 new cases this year in the United States, okay? But if you come down and you look at number 2, what the arrow is showing you, it's lung. So there's about 3 times as many new cases of prostate cancer this year as you'll see of lung cancer. For women, it's breast. Again, about 3 times as much, okay? But now jump down to the lower level, you're gonna see the estimated deaths that we expect to see from each of these diseases. And what happens is immediately, for men, the prostate gets overtaken by lung cancer. So that's telling you something, that the behavior of lung cancer in African American men is so aggressive, it's more aggressive than a cancer that you see 3 times as much with them. For breast cancer, Still, breast is number one, but remember, there's 3 times as much. Lung cancer is a very close second. So this is telling you that the behavior, again, is more aggressive in these populations, which means there needs to be a higher focus on finding it early and treating it early. Next slide. Okay. And so it's just to give you an idea, because I mentioned that despite smoking equally or even less than other races, the prevalence of lung cancer in African Americans in the United States is higher. So over here in the green section, we have lung cancer incidence rate. You have African Americans, African Americans across the board, whites, and then Native American and Alaska natives. So let's jump over to the smoking because you have the same comparison here. Okay, so African Americans and on the lighter yellow, that's the smoking rates for men, and then the orangish color for women. So African Americans about 25.5%, 18%. For whites, 23 for men and 20.6 for women. So they're about the same, right? Everybody can see that? Now jump back over and look at the incidence rate. You have 10 points higher incident rate. So this is telling you, despite smoking equally, the rates of lung cancer are higher. That tells you that there is something that makes African Americans more susceptible to the deleterious effects of tobacco smoke, which is resulting in more cases of lung cancer. And if you really want the example, let's take a look at the Native Americans, right? Look at the men. They're smoking a whole lot more, almost twice as much. But their cancer rates are almost 30 points less. Now, I'm not going to go out and tell them, go ahead and keep smoking, because that's still bad. But the reality is there's differences that we need to pay attention to for different populations. And if we're going to get these disparities better, we have to recognize them and focus on these populations. Next slide. Okay. So here's another example, especially in Kentucky. Remember, Kentucky's the number one for developing lung cancer across the United States, the new cases across the United States. But they're not the number one in smoking. Now, y'all are pretty bad. We were driving down. We saw all the smoke shops and whatever else, and there needs to be some focus there. But this is telling you that there's something else contributing. So I would tell you, if you see lung cancer popping up in people that haven't smoked, especially if there's, we've been to places where multiple people in the church are developing lung cancer, or in families, or in neighborhoods. They need to probably be testing for radon, because remember, we're at 36% of houses that are tested are above the rates. Next slide. Okay. So I'm glad when we had the pre-question, someone mentioned prevention. I think that's extremely important, because in the United States, we know the risk factors. One of the risk factors is smoking, especially for African Americans. And we talk about the screening and detecting early, and for the people that are high risk. How about the prevention side? We need to focus on preventing people from starting. And it looks like as we go through time, younger and younger, that's starting. This is a study that looked at middle school students, not even high school, middle school students. And they found that of all middle school students that they had in this study, about almost 5% of them used any type of tobacco product, right? And the thing about that is that girls were actually worse than the boys. Usually it's the other way around for things, but girls are actually worse than the boys. And here's the thing. So for young kids, a person's brain is developing from birth until they get to about 25, and that's when it's kind of reached its peak, and then it declines after. I started declining a lot earlier, but that's when it starts declining there, right? So as they start these addictive products early in their life, and that brain is developing, the brain learns that this is part of what's normal. This is what should be accepted. So it gets incorporated in there. So that's why it's harder for them to stop. Because when they go to high school, these numbers keep going. And then they get out and they keep going. Next slide. And it's the hardest thing to do that we have to keep in mind is we cannot go to our kids and tell them it's bad for you to smoke if what? Yeah, if they see us doing it. Okay, next slide. The other thing is when we talk about prevention, we have to understand exactly what it is about smoking and what we're smoking. I learned a long time ago when I see, because I work in a hospital, I diagnose about 180 new cancers each year. 90% of those are African Americans. I've learned when I start asking about the tobacco use history, right? Not how long have you smoked and how much do you smoke. I need to ask, what do you smoke, right? Because we're seeing a lot more in different situations. Next slide. So give you an idea of why this is important, and I think what people don't understand, okay? So the smoking, which is the risk factor, right? It's not the nicotine. You hear about nicotine. It's not the nicotine that causes the cancer. It's the 6,000 other products that are produced from the tobacco smoke that is causing the genetic changes. These benzene, formaldehyde, all the other things that are put into it. That's what's resulting in the development of cancer. The nicotine is the addictive part. Nicotine is one of the most addictive products that we know. The only two things more addictive than nicotine are cocaine and heroin. So it is that bad. If nicotine were a new product coming out on the market now, the FDA would have a problem with it. But you know what? It's so tied into money and politics and whatever else that it gets a pass. But it's so tightly regulated that we know average cigarette maybe have 8 to 10 milligrams of nicotine in it. Okay. So I had a young patient there. He's 34 years old. He says, man, Doc, I don't smoke that much. I only smoke about 4 a day. And then that's why I said, 4 what? He said, 4 Black and Milds. I said, the little cigars. Yeah. I said, do you know those have 100 milligrams of nicotine in it? That's the equivalent of 12 cigarettes, a little more than half a pack. You're a 2-pack a day smoker. Right? Or you take the larger cigars, 200 milligrams. That's 25 cigarettes in a sitting, okay? The thing about this is the tobacco companies know this. Some of them are actually fortified with nicotine, and they market to specific populations because there is no coincidence that these are named Black and Milds. Next slide. Okay. And then we've seen the rise of the vaping, right? And the little pods. So if we take a pack of cigarettes, we know a pack of cigarettes, 20 cigarettes, right? But you start looking at the jewel pods. A jewel pod, equivalent of 41 cigarettes, okay? And you start moving up to the puff bar, which is 50 cigarettes worth there. And I don't like that they're putting the menthol in there because the menthol was actually intended to soothe the effects that would irritate your airways so much that you would stop. And so they started using menthol to keep people smoking. So it's a little bit smoother for them while they get 50 cigarettes worth of nicotine in there. And then it's a whole lot of other chemicals that we're seeing. In this new pod, 90 cigarettes, and they're starting to make these pods where you can get like multiple, like 10,000 puffs out of one pod right there. And the thing about it is it's so easy and it's so addictive that people they'll puff it all day. You get these, you see these huge plumes of smoke they're blowing out, right? And this is why, it's the addictive part of the nicotine that keeps driving back. And for the little kids, when they were flavored and whatever else, they know that what happens is eventually when that kid runs out of money and those become too expensive, they're just gonna go to cigarettes. Next slide. Okay. These hookah bars, okay? Very, very trendy. Okay, you'll go, it's kind of gross, really. But they'll go to the hookah bar, a group of 5 or 6 people will go. They'll rent for an hour session. They'll have the hookah thing up, has a bunch of nicotine and other stuff, and they're passing this thing around and they're inhaling and blowing. So look, if somebody hands me a soda with a straw in it and say, do I want to sip? I'm looking at that straw crazy. I'm not putting something else that's been in somebody else's mouth, right? And then they're now the secondhand smoking, they're passing this around. But what they do know is in that 1 hour, each person gets about 200 puffs per session. And then you have all the secondhand smoke. Well, that 1 hour session is about the equivalent of 100 cigarettes, right? And it's that addictive part of the nicotine which is going to flip them back, and it's in that social acceptance which is going to keep and drive that smoking to continue on. Next slide. Right? And the advertising doesn't stop, right? When the advertising became sort of taboo for cigarettes, and now you have, for the new pods and the vaping cigarettes, they just advertise for younger, healthy, energetic people, beautiful people. Let's see what they look like in 50 years. Next slide. Okay. I understand and I sort of get this whole legalization of marijuana, right? But what we do need to know is that in the past, we didn't know how much that smoking marijuana would, or if it even contributed to developing lung cancer. But now we know. We know that if somebody is a heavy user of marijuana, then they have a twofold risk of developing lung cancer at some point in their life, right? And the definition of heavy user, 50 times in a lifetime. Not a week, like most of my patients, sometimes a day, 50 times in a lifetime, right? That's what give you a twofold increased risk of developing lung cancer. So when we talk about this prevention component of it, we have to get to the prevention part has to be education related, right? Because we're not going to make a difference until we educate and then we start acting on what we're educated on. Next slide. Okay. So with all of this, and then you mentioned about what can we do to, in terms of what's available to find early and start treating early? Well, screening. Next slide. Okay. So a lot of times what happens, and especially men, myself included, is like, okay, we don't need to go to doctors, we don't need to do all this screening stuff because I feel good. I don't have any symptoms yet. And then when symptoms come, we start playing them down. The problem with symptoms, especially with lung cancer, is once you start developing symptoms like a persistent cough, the shortness of breath, you may go somewhere and get treated for a pneumonia. And then you go back, the pneumonia's still there, and they give you more antibiotics, it's not working, it's not working, it persists. Those type of things. Or you have arm pain, you have back pain, or you're just losing weight or coughing up blood. Okay, by the time you have any of those symptoms, that cancer is well advanced. Okay, you've missed the opportunity to catch it early. Next slide. Okay, so the purpose of screening is to detect lung cancer before there's any symptoms. Okay, give you a general anatomy lesson right here. Okay, so this is a CAT scan of a person. The sort of the grayish areas and everything, those are your lungs. If you go to the edge of the lung, a lot of nerves there. Like if you ever hear somebody that's broken a rib or bruised a rib, they're in pain, right? A lot of nerves there. If you come into the airways, a lot of nerves there, right? That's why if something's tickling you, you got to cough and do whatever else. But in the middle of the lung, not a whole lot of nerves. And right where that circle is, that little dot in the middle of it is an early lung cancer. There's no nerves there, right? So the lung cancer has an opportunity to grow undetected unless we go looking for it at an early stage, okay? Right, and what we do know is if you screen, by screening, it gives you a 20% chance of dying. If you screen with a CAT scan, 20% less chance of dying of lung cancer if they detect it early. And just by screening in general, you get a 25% chance, if you're a high risk, of not dying of lung cancer. Next slide. So who should be screened? This is important. If you know somebody that fits into these categories, or if yourself you do, if you're between the ages of 50 to 80, if you currently have smoked or smoked any time in the last 15 years, or if you have what we call a 20-pack year history. And what that is if I smoked 1 pack a day for 20 years, that's 20-pack years. Okay? If I smoke 2 packs a day for 10 years, that's 20-pack years. So if I get 20 or above, you meet the criteria for getting screened. Next slide. Okay. So actually, and this is what I thought was pretty amazing, okay? So the national average for screening, the yellow line there, of people that are high risk is about 5%. We're really not doing as good as a nation. But for Kentucky, you guys are doing really well. 18% of the people who are high risk are getting screened. But then you still have a high rate of lung cancer and smoking. So something else needs to come into play here. Somehow we're missing a group. And maybe smoking's not the only reason that people are developing lung cancer here. Next slide. So screening, if you screen and you find it early, does it really help? Next slide. Okay. Well, here's what we know, especially for blacks versus whites, and this is why, as a nation, we need to pay specific attention. So if you look at the 3 areas that we have that we look at mostly, whether it's local in one area of the lung, whether it's regional, it's in the lung and the lymph nodes, or if it's distant, it's already spread to the rest of the body. And what we do know is blue is whites, red is blacks. Blacks are less likely to have it found at the time they are diagnosed in the early stages. In sort of the mid-regional stage, it's about equal, but they're more likely to have it found at late stages, okay? So there needs a little bit of focus on that, finding it early. Next slide. And this is data specifically for Kentucky. So you can see that finding it early, if you take the dark blue, that's whites, and the light blue is African Americans. Okay, early diagnosis, blacks here in Kentucky are less likely to be diagnosed early. So we need to focus on the screening a little bit more. They're less likely to get the curative surgery for lung cancer. And they're about equal for not receiving any treatment at all. Okay, so think about having lung cancer, being diagnosed with lung cancer, and both blacks and whites are somewhere close to 18 to 19% of not getting any treatment at all. Next slide. So I have to give you a little understanding of why it's so important. You get screened, they find something to move very quickly on it because lung cancer can spread very fast. So when I talked about when you get that one cancer cell and it goes from 1 cell to 2 cells and then 2 cells to 4 cells, that's what we call a doubling time, okay? And it's really important because all of a sudden you can go, and the way to think about it, if you're found to have a cancer that's about the size of a teaspoon, and you wait over that doubling time, then you're gonna have 2 teaspoons. And you wait another doubling time, then you're gonna have 4 teaspoons worth of cancer. And before then, it's gonna spread. Next slide. So for the 2 different types we talked about, for the non-small cell, remember the bigger cells there? That doubling time is about 60 to 90 days, 2 to 3 months. So you think you find you have cancer and you say, okay, I don't like that doctor and what he told me, and I'm gonna go find another, and then start from scratch, and by the time you get all your appointments, another 2 months has gone by, and you have twice as much cancer. Okay, so this is the point where you find it early, you move early on it. Next slide. Okay. And with you find that lung cancer, that non-small cell lung cancer very early, the best treatment if you find it early is to have surgery. Okay? Because if you can have the surgery and get it out of the body, that's the best one. If not, there's alternative treatments of the chemotherapy or radiation or a combination thereof. But the best thing is not to wait. You get the diagnosis, we have to get those people to get the treatments and start moving on, the staging and the treatments moving. Next slide. Okay. And the traditional treatments, I mentioned surgery is probably the best at early stage, chemotherapy, which medications through the IV, or radiation to radiate the cells to keep them from growing, kind of best. If we start looking in towards newer treatments, and sort of we can test for biomarkers, specific aspects of the cancer that they can focus the treatment on, whether it's how the cancer grows its own blood supply or how it spreads, and we can attack those parts of it, the survivals can be better. Okay, next slide. Okay. Here's the thing, and this is where the disparities comes into play and what we need to focus on. If we take that early stage that I mentioned, that one that's best cured by having surgery, then in this study, they looked at those people that had the early stage and actually went through the surgery. We saw that white men had the surgery and were cured about 93%, white women 93%, black women 90%, black men 65%. So there's something there. Even when you have early stage, it's not happening, right? And that may not be biology, right? Or environmental, that may be healthcare, whether or not we're going to get the treatment there or whether or not it's available, and that's where we need to focus our attention. Next slide. Okay. And again, surgical treatment, less likely here in Kentucky for African Americans to receive the curative surgical treatment. Next slide. Next slide. Oh, thank you. So, switch to the non-small cell. This is the most aggressive. Remember I said they're smaller, they grow fast, they spread fast. That doubling time is 1 month, 30 days. You get the diagnosis. When I tell a patient they have small cell, we got to get their staging scans. We have to get them in. They got to get started on treatment. Next slide. Because this is the most aggressive, okay? Most patients with small cell, only 5 to 10% are still alive in 5 years. It is that aggressive. In the extensive stage, if by the time they found it, it's already spread, 6 to 12 months even with therapy, is expected lifetime. And only 10% of the people are disease-free even after starting treatment. So it's very aggressive. The outcomes are not good. So we really move quickly on them. Next slide. Okay. Small cell, it has the 2 stages. Remember I mentioned you have the limited, it's in one spot, or extensive, it's spread to other places. Common treatment, surgery cannot happen fast enough to get them cured. So we actually moved to chemotherapy and radiation. Now on the horizon, there's newer immunotherapy where your immune system is being trained to focus on and help fight along with the other medications. And that's actually shown a lot of promise in the market. Next slide. Okay. But the other important thing we need to focus on is we start talking about prevention. We can't really prevent till we know what works and what doesn't work, okay? And with this, we have to think about clinical trials and how we make improvements that focus on specific populations. And one of the things that happens is the African Americans have not been very good about participating in clinical trials, especially for especially for cancer in general. If we look at who's represented in clinical trials for cancer, Caucasians about 83% of the time, African Americans on about 6% of the time. And the problem with that is that the treatment guidelines, the treatments that work, don't really tell us if they work for our population, right? So I know there's been some bad history. I'm not going to go into a lot of that, but what we do know is now clinical trials now are not the same way they were when those bad things were happening. There's been a lot of safeguards come in. There's a lot of safety come in because nobody wants that to happen again, okay? So there's some benefits from participating. One is you're either getting the new treatment or you're getting the standard treatment. Okay, there's none of the placebo, watch the natural progression of the disease. You're going to get some treatment, and it's especially helpful for people that are either uninsured or uninsured. Okay, we start to understand about how different treatments, how different protocols work for our specific population. Okay, and you receive medical care. You're going to get some sort of medical care, and all of this could help extend your life. Next slide. Okay, so a couple of take-home points. Next slide. One, I hope I answered your question about prevention, okay, because it's very important. Just remember what we said and what we learned about, and not only just taking what we heard, but actually spreading it to other people and educating them, and then making changes that even the young ones can see that we're making amongst ourselves. Next slide. Number 2, if you are at risk, or you know somebody that's at risk, and they meet the criteria to find a place that can get screened. Next slide. Okay. And remember, clinical trials are beneficial. It's not only beneficial for the person, but it could be beneficial for a specific population as well. Okay. Next slide. Okay, and I'm done. Thank you. Got it. Did I break it?
Yes. You know, Dr. Flanneau is kind of interesting because so often we hear something black, it's always mean black person or angry black person or threatening looking black person. The one time we hear something good about black and mild, it's a damn cigarette. It's kind of an interesting transition there. Well, the question comes down to what happens after a diagnosis is made? What do you do? How does that whole process go? And also, how do we go about getting the screening thing done? And to try to answer these kinds of questions for us, our next speaker is Ms. Ursula Mathis. Ms. Mathis is the Director of Oncology Service Line at Phoebe Putney Memorial Hospital Cancer Center in Albany, Georgia. She'll be giving us a combination of talks on screening to diagnosis, wellness-based shared decision-making approach, and also lung cancer navigation, the role of nurse navigators on the lung cancer treatment team. Ms. Mathis. And as you come up, Ms. Mathis, perhaps maybe I'm putting the cart before the horse, but I put in I don't know how many of you all are good with directions, but I put in my GPS, Burnett Baptist Church, and I wound up 10 miles away from where I was supposed to be. So how is a patient supposed to get from point A to point B when you're talking about getting them screened and make the diagnosis? Ms. Matthew.
Good morning. I'm good. Thank you. And we're going to talk about how we get from point A to point B when we talk about the navigation side of it. My name is Ursula Mathis. As Dr. Tussin introduced me, I'm delighted to be here, and thank you all for coming out for such a worthy cause. I do have one question. How many healthcare providers or healthcare workers do we have here today? So about half. Okay, so about half. I kind of got that feeling, so I really want to kind of talk to you all today as well about navigation, shared decision-making, and how we engage with patients to make them feel safe, to make them feel that they're in a trusted environment, and to make them feel that they're able to get optimal care from us as healthcare providers. So I want to go down that road a little bit, if you don't mind as well. If we can start on slide 9 for me. I'm not good with slides, y'all. So I'm going to be all over the place, and you're just going to say it's not talking about what the slides are, but the slides are in your handout, and I'm going to try to cover most of them. So we're going to talk about shared decision-making as we start. We talked about lung cancer screening. Dr. Fanal laid it out real well as to what the criteria for lung cancer screening is. But if you see one thing on here, it says shared decision-making. Next slide. And also the importance of knowing your family history. History is important, and when we engage with our healthcare providers, the more information that we can give them, the more information that we know, the better decisions we can make as how we move forward with your health in the healthcare journey. So shared decision-making is a method that should be used in every healthcare environment and every decision that you make regarding your health, whether it's to take a vitamin or whether it's to take chemotherapy. The information that you share with your provider needs to be open dialogue and needs to be where you can hear it, where you can understand it, and where you can make an informed decision about your options in your healthcare journey. Next slide, please. So let's talk. In this discussion, we as providers ought to provide education that includes choices, options, and decisions. Your healthcare journey should not be a dictatorship. It should not be, you got this, take this. And I haven't asked you your family history. I haven't asked you your allergies, haven't asked what else you're taking. Is anybody else in your household have any of these similar symptoms, diseases, diagnosis? Next slide, please. All of that should be included in this discussion that we're having with these patients, or patients have to advocate that these things are included, and you equip yourself to ask these questions to your providers. So essentials in the shared decision-making is that we should seek participation, ask the patient if they understand, engage the patient to the point where they have to have dialogue with you. If I'm talking to a patient and I realize that I work in the cancer world, so this is a diagnosis that you just got, so you're in shock, you're in disbelief. A million things is going on in the patient's mind at that time, and they're probably hearing less than 5% of what I'm saying. So that means I have to engage them and reinforce what I'm saying. That means maybe at this point, I have to put the diagnosis to the side and ask, what are you thinking? What are your fears? What do you need from me as your healthcare provider to get to the next step so that you can retain what I'm trying to say to you? It's that extra second that makes the difference in this patient's outcome and the prognosis. So we want to explore different treatment options. I can say National guidelines says you have a stage 2 cancer and you're going to need chemo. There are a lot of chemo options. There are some oral options. There are some tests that says your reoccurrence rate that should be examined or determined as to whether you have an option to take chemo or not. So we have to ask those questions because, and you have to know the questions to ask. That's why on the patient side, you need an advocate. That's where your navigation team comes in. Because if I have an early stage cancer, I want to know my options. Okay, if I take chemo, what's my survival rate? What's the options of me being totally cured? What's the options of this coming back in X amount of years? Versus if I don't take the chemo. In some cancers, the options are the same. In some cancers, there's a higher occurrence rate with or without chemo. Some cancers just need surgery. Some need chemo and radiation. But there are treatment options, there are survival rates, there's national data, national guidelines, and there's genetic testing available that tells you your outcomes, your reoccurrence rate, your genetic profile. That means if your immediate relatives are at a higher risk as well. And all of this should be part of the conversation so that you can make an informed decision as to how you want to move forward with your journey. Because the journey is personal. It's yours. You have a team around you. You have your support system. You have your loved ones. But the journey and the decision is yours. And it doesn't help if everybody around you understand what's going on and you don't. So it's important that you're a part of that decision and that you may help make the decision based on the information that you've been given. Okay, next slide, please. So again, we want to seek the patient's participation. We want to communicate, summarize, ask questions, include them and their family members in the decisions, and then remind or discuss what's going on. Next slide. But when I say include them, a lot of times patients come, they bring their daughters, their sons, their husbands, especially when they bring someone who works in healthcare. Oh, wow. We got something on our hands then. Because they know everything opposite of what the physician is saying. They've already made the decision because when I had it, or when such and such had it, they did this and we was fine. They don't know your pathology. They don't know the grade of your disease. They don't know whether such and such had the same risk factors. They don't know the aggressiveness of your disease as opposed to the other. So everybody got to come in with a clean slate. Medicine is really precise now. And my plan is not going to be your plan. There are some national guidelines. There's some starting points that we all must start at. But there's something about me, uniquely and wonderfully made, that's different from you. So our plans may be different. Our trajectory is going to be different. I may need something that you don't need. You may qualify for something that I don't qualify for. And not only that, next slide. My psychosocial or my economics, my needs may be totally different from yours. And this is where that navigation and advocacy piece comes in. You can stop with the slides. This is where all of that comes in. I can't follow slides, y'all, I'm sorry. I'm trying. But this is where that comes in. Because if this patient is part of this decision, and this physician has sat down and met this patient at eye level and see the fear in this patient's eyes, the devastation that they're having to deal with, Now I have to help you navigate this process. I need to know some questions that only if you can trust me, only if I've made you feel comfortable, that you're able to have these conversations with me. And if you can't trust me, I can't treat you and expect a successful outcome. If you can't trust your healthcare providers, meaning you don't feel comfortable asking questions, you're upset every time you come about the wait time, you feel that there's some disparities in your care, you feel that there's some bias in your care, then in the back of your mind, even if you're cured, you're always going to feel like there's something you missed, or there's something else they could have done, or there's something that somebody else got that you didn't get. So as providers, we've got to meet patients where they are, whether it's the doctor, the extenders of the doctor, the navigators, the educators, the administrators. We have to learn to meet patients where they are. By meeting them where we are, we ask them what they need. We help them get what they need. We take the burden off of that patient to navigate this process, and all they should have to worry about is being healed and going through this journey. So I need to know your psychosocial dynamics. I need to know your fears. I need to know what is preventing you from getting to these appointments if you have transportation. I need to know your housing situation. I need to know your support system, your work or your lack of work, your resources. Because all of that matters in the trajectory of your care. It all matters. But if you feel that that is none of your provider's business, that means that you're not comfortable with that provider. We have to be able to self-advocate, and that starts with us. The provider has the responsibility, but we as patients, we as African Americans, we as women, we as men, we as human beings, first of all, have rights, but secondly, we have to be able to self-advocate. So that means that you have a responsibility to do some homework, to know your family history, to know your social habits and be able to meet yourself where you are and have an honest conversation about them. What you do, when you do it, how much you do it. We heard it all before. Trust me. ALL, all. There's nothing new under the sun. But you got to have these conversations so that I don't put you on medications, put you on trial therapies, put you on regimens that we know that you can't complete. It sets you up for failure. It doesn't help me to put you on a regimen in radiation oncology that's going to require you to come twice a day and have these treatments, and you don't have transportation, but you didn't tell me. I did what I was supposed to do on paper. It's covered legally. I made the recommendation. But the paper's not what's the concern. The patient is where the concern is. The outcomes, the safety, the quality, and the patient satisfaction is what should be the concern. So I need to know whether you have transportation, because there's resources available. I need to know what your family history is. I need to know whether your preference is a less aggressive treatment that may result in a reoccurrence but doesn't require XYZ, or an aggressive treatment that may make you a little sicker, that may require a little bit more social help, that may require you to have to stop working. But these are your treatment options. I may suggest a clinical trial that you may have some hesitancy to. Like Dr. Fanal said, based on history, based on what you heard, based on this, based on that. But let's sit down and talk about the facts. Let's sit down and talk about the pros and the cons. Let's sit down and talk about what the outcomes of this trial would mean for you and your family, or you and your situation. All of these things have to be taken in consideration when we're making shared decision-making, we're making treatment decisions, and when we're advocating and navigating this process of any healthcare journey. I work in a cancer center and I talk about cancer, but this applies to every area of our lives. When it comes from screening, know the screening guidelines. Ask, am I eligible for, what type of screenings am I eligible for? What type of screenings in my age group should I be having? What do I need to do? That's why everyone needs a primary care physician. We need to be proactive, not reactive. Don't wait till the rain starts to get an umbrella. Know that it's cloudy and I might need to take this umbrella with me. So that's what prevention and screening is. Prevention is the greatest chance of cure of any disease. Prevention does not mean I get my mammogram every year, so I'm never going to get cancer. No. It means when they see it, I know it wasn't there last year. So I'm catching it early, and early detection is the best detection. Early detection gives me more treatment options. Early detection gives me the opportunity to make those choices for myself. Whereas if I catch it at a stage 4, this is the only option I have. And the outcomes of this option is really bleak, whether I do it or don't do it. Because the later we catch cancer, the later we catch heart disease, the later we catch most diseases, the less treatment options and choices we have. So prevention gives us choices and options out the gate. It gives you the opportunity to get ahead of your journey. Prevention also requires you to see a primary care physician yearly. Get a primary care physician if you don't have one. If you know somebody that don't have one, encourage them to get one. Everyone needs a quarterback to their healthcare journey. Everybody needs it. So if you're a smoker, you can talk to your primary care physician about that. If you're not a smoker, but you feel like you've been brought up around people that smoke, or you've had exposures at work, or you have exposures to asbestos, if you don't feel that you meet these lung cancer screening guidelines, talk to your healthcare providers. Because the test can still be ordered, it's just not called a lung cancer screening. Now it's just called a CT scan. It's the same test. But your concerns are addressed. You've got a baseline. And that's another thing, when you get your screenings and you move and you go here and you go there and we do these promotions, that's awesome. Get them. However you can get them, get them. But when I say know your history, this part of your history. When you come here for a mammogram this year, you need to be able to say, I got it at North Star last year. Because this mammogram by itself means nothing if I don't have the previous years to compare it to. How do I know that this little lesion that I see hasn't changed if I don't have anything to compare it to? Comparison is your history. The lesion can be biopsied every year and come out benign, which means non-cancerous, or it can be biopsied once. They put a little clip in it. And every year it's going to show up on the exam because it wasn't surgically removed. But the radiologist or the physician or the interpreter of the x-ray can see this has been worked up. It was there last year, it was there this year, it hasn't changed. Or they can see this thing stayed the same 5 years. Now this year is doubled in size. It needs to come out. That's the importance of screening, so that we can monitor year after year. Screening is not a one and done. You can't say, I got my screening last year, I'm good for this. No. Some screenings go 3 to 5 years. but your doctor, your primary care physician, will give you those recommendations and let you know when you should or should not be screening. If we smoke, we know smoking is a major contributor to almost every disease. Heart disease, lung disease, cancer, kidneys, everything smoking is not good for. But the shame is not in smoking. The shame is knowing better and not doing better. So we don't condemn you because you have a smoking history. We don't condemn you because you drink. We don't condemn those that have whatever social habits that they have. But we encourage you to be forthcoming about them so that we can seek prevention to decrease and then stop. I tell my patients all the time, when I smoke, and they kind of shame that they smoke. Oh, don't be ashamed. Let's see what we can do to smoke less. Let's stop smoking in our house. Let's not smoke where we lay our heads. Let's not smoke indoors at all. Let's not share your smoke with me. Inconvenience yourself to have to go and do this. And then they smoke less and less and less. They gain a little weight. Hey, we'll work on that later. But it's how we have the conversation. I have one physician, we have to tell him all the time. He come in, oh, you fat. Oh, you still smoke. I'm not going to treat you if you this, that, and the other. No. Yes, you are. Yes, you are. And one last thing I want to say about advocacy and patient advocacy. We set the tone for our healthcare visits. If we come in the office and we frustrated because we don't waited 2 hours, waiting is impatient and an inconvenience for all of us. But I tell patients all the time, I don't want to walk in nobody's office and I don't see nobody. I don't want to walk in a restaurant and ain't nobody there but me. Because that means it ain't good. Something ain't right. So if I walk in here and my doctor got 15, 20 people waiting on him, for one, I know he's spending time with these patients, that's how he getting behind. But then I know that he in high demand, so they want to see him. So we got to change our mindset, because it's all in mindset and perception. When I'm sitting there, I'm like, you know what, I understand, because I'm taking notes. Let me remember, I got to ask him about this. Because I'm expecting now, you done made me wait an hour. When I get in here, they got to wait an hour. I'm going to ask you everything I thought I wanted to know. Then ask about their extenders. Dr. Tuckson, I know you got 1 million people to see, but I don't quite understand. So do you have a navigator? You got a social worker I can talk to? You have somebody that can take me to the side and kind of just break this down a little bit more for me? The doctor may have a language barrier. Is there somebody that can explain this to me so I can go home and explain it to my kids? Come with time. You know that you're not going to your primary care physician's office. You know you're going to specialty care, whatever disease it is. Come with the patience and the time, knowing that you want to leave with understanding about what your next steps are and what you want to do about you. Because that's who it has to be about, you. Make it real personal. It's got to be about you. Demand the time, the resources you need to make informed decisions about your health care journey. Be honest with yourself. If you know you come with all these comorbidities, bring your medications with you. I'm diabetic, I'm hypertensive, I have congestive heart failure, I have XYZ. If you are not, imagine a patient that comes into the office, have all these things going on. does not have a primary care physician, does not know their family histories, or do not want to share their family histories, we put them on these drugs that are very toxic, and they go into heart failure because they never mentioned that they take heart medications. Or we don't have records from a primary care physician that says this is what they take and this is what they do. Or they never mention that they use recreational drugs. Because there are alternative medications that we can put you on. If I know you use recreational drugs, I'm not going to give you a port to go home and inject, and it goes straight through your bloodstream and kill you. No, we're going to have to do your medications IV when you come. So it's necessary that we, first of all, advocate for ourselves, have conversations with our physicians, and insist that they have them with us in order to change the trajectory of the healthcare journey and have better outcomes for our cancers and survival rates. Thank you all for listening.
Thank you very much, Ms. Mathis. Those are lessons to live by, to be quite honest about it. You touched upon something that's very interesting. Sometimes, and Dr. Flanell also touched upon this, but when we look at survival rates from people, and sometimes it has nothing to do with the initial disease itself, but there's a lot of other things that are going on with the patient. And one of the things that's too often overlooked as a reason why there's failure of treatment is the patient's nutritional status and the role that nutrition plays in our overall health. And to try to give us a little better understanding of nutrition as a factor in supporting lung cancer care and treatment, we have as our next speaker, Ms. Deja Ivey. Ms. Ivey is a registered dietitian nutritionist. She is a published researcher. And what I find fascinating is she was selected as the Academy of Nutrition and Dietetics Foundation Leadership Scholar back in January of 2023. She's also owner and founder of Ivy Healthcare Consultings. So let's sit back and hear a little bit about food and how this helps us. Ms. Ivey.
Good morning, everybody. First of all, if we could give a round of applause for our other two speakers. They were really phenomenal. I always learn so much from these sessions, so thank you for having me. Like the good doctor said, my name is Deja Ivey. I'm a registered dietitian. And if we'll go to my slides, I'll tell you guys a little bit about my background. Okay, I'll get started while they're pulling them up. But I received my bachelor's degree from Life University, Marietta, Georgia, in dietetics, and my master's degree from Georgia State University in health science with a concentration in nutrition. And I got my clinical training, critical care at Grady Hospital. I did some diabetes work at Children's Healthcare of Atlanta, and then some acute care work at Piedmont Hospital. My practice affiliations are Emory University Healthcare, as well as the Winship Cancer Center that opened last year. So I have diverse experience working with cancer patients with different types of cancer using medical nutrition therapy. Still no slides? Okay, well, I'll start with a nice question that I wanted to ask you all anyway. Who here, by a show of hands, thinks that cancer or cancer cells eat? Raise your hand if you think cancer eats. Okay, about half the room. You are correct. And cancer actually has a preferred source of food for carbohydrates, right? So when we think about our three major macronutrients, we have protein, fat, and carbs. And cancer, for whatever reason, prefers carbohydrates. So one of the things that we can do is monitor how many carbs we're eating when we're talking about either preventing cancer or managing it, right? So what kind of carb foods do you guys like? And you can yell them out to me. I know there's no mic being passed around, but what do you guys like to eat? What'd you say? One more time. Pasta, absolutely. What else? Bread, What else do you guys eat? What kind of carb foods? Cake, yep, we have our sweet items, cakes, candies, desserts. I know we said pasta, rice, bread items. Any healthy carbs that we can think of? Avocado. What else? Carbs that are healthy. We talk about it all the time. We want to eat our vegetables and our fruits. Fruit, right? So sorry. Sorry, y'all. I have a really great slide. Oh, okay, awesome. We just got to go back. I think they're still working on it. But one of the things that I find interesting, and I know we have some more seasoned folks in our audience, is how big fruit has gotten over the years, right? So really, one of the things we can talk about is the serving sizes of fruit and what they're supposed to be. So how large do you think a normal apple is supposed to be? Yes, the size of your fist, right? Pretty small. Nowadays, we probably see apples that look like the size of grapefruits, right? The same with bananas. Usually half a banana is a serving of carbs, as well as like a handful of grapes. And there are different things that we can do with measuring our foods using our hands. And I feel like a few of you in the audience might know what some of these tricks are. Has anyone ever heard about the trick with the size of your palm of your hand and what that's supposed to represent? Yes, the proper portion of protein, about 3 to 4 ounces. You can also do it with your fist. So if you have a clenched fist, that's about a cup of rice. If you have a fist that is pointed out as if you're punching, that's about a handful of nuts or seeds that you're supposed to have. And then the part of your thumb is about 2 tablespoons, which is really helpful for like butters and peanut butters. Okay, we're still working on the slides. Okay, pulling up the slides on my phone.
Could you answer a question some
Sure.
of us probably have? When a person is undergoing chemotherapy, oftentimes they're not able to eat much. But what are some of the things we need to make sure that we're getting in to keep us healthy as we're going through this process?
Yes, so actually my very next slide was about antioxidant and anti-cancer foods. So some of the things that we can eat that are very nutritious are our yellow and green produce items. So what are some yellow and green produce foods that you guys like to eat? Green beans, squash, absolutely.
Broccoli.
Yes, broccoli and cabbage are cruciferous vegetables. What'd you say?
Brussels sprouts.
Yes, Brussels sprouts.
You're the only one.
Excellent. Excellent, guys. And some of the benefits of those are they're fiber foods. Oh, yes, asparagus too. Excellent. They're fiber foods, so they help us to excrete toxins, which is very important with preventing cancer. They also have antioxidants, which is something we hear about a lot with like wine and chocolate. Really, they're different benefits and abilities of the foods that they're able to protect our cells from cancer, as well as other oxidative damage in the environment. They're also natural laxatives, and they're rich with vitamins and minerals, which to Dr. Tuckson's point, there are a lot of cancer patients that are very malnourished. So you really want that to be the foundation of your diet. Some other foods that we want to eat for a protective factor against cancer is specifically cruciferous vegetables. So I know some of you guys mentioned Brussels sprouts, broccoli, cauliflower. All those are great options for that. Cruciferous vegetables are known to be anti-inflammatory, and inflammatory is very common with cancer, and they also have the antioxidants. They also limit the production of certain hormones related to cancer, so there's something you want to incorporate in your diet. And then lastly, we have omega-3 fatty acids as a protective food. What are some foods you guys have heard of that have omega-3s? Fish, absolutely.
Salmon in particular.
Yes, salmon, mackerel, sardines. What else? Any other kinds of foods that you guys have heard of?
Avocados.
Yes, avocados, also walnuts, flax seeds, lentils, yep, and eggs. Enriched eggs also have that.
Okay. What about flaxseed?
Yes, flax seeds. Okay, so what to avoid? So some of the things that we want to avoid are quick bites, right? Fried and fast foods. Really anything that comes in a package. It's been processed, it's known to be high in carbohydrates, it's probably also very high in salt, which isn't good for our health. So really one of the best things we can do is when we go into the grocery store is shopping around the perimeter, getting all the fresh fruits and vegetables and proteins and avoiding those middle aisles more. Another thing that we want to avoid because it increases our risk factors are red meats and alcohol. What kind of meats are considered red meats? Pork, yes, our white red meat, often forgotten about. Yes, what else?
Beef.
Yep, beef. Is that it?
If you come from Eastern Kentucky, what about possum?
Yep, it's really just beef and pork. So everything else is still available to us, and those are all lean meat items. Turkey, chicken, eggs, fish. And then lastly, I wanted to go over how to read a nutrition. Oh, I didn't realize they were up. Sorry, guys. But yes, we've been over everything on this slide, but I'll just recap since we're already here. So these are our protective foods. So yellow and green fruits and vegetables. Again, those benefits are fiber, they're antioxidants, they're going to protect our cells, they're natural laxatives, they eliminate toxins, and they're rich with vitamins and minerals. Our cruciferous vegetables. The image is a little bit blurry, but to the top right, there are a bunch of different examples, including radish and other types of veggies. They're anti-inflammatory, they're antioxidants, they detoxify, and they limit those productions of hormones that are linked with cancer. And then we have our omega-3s. Next slide. Yes, so tips for the grocery store. So we all know that inflation is real, and it's very, very hard to find healthy, balanced, accessible, affordable meals. So one of the things we can start with is taking inventory at home and then rounding out those meals, especially to add in some anti-cancerous foods. It's helpful to plan your meals for a week so you can cook and pack in bulk. You want to make a shopping list, use rewards cards. Shopping in season is extremely helpful. You'll find the cheapest fruits and vegetables to be the ones that are in season. And then you can also blanch your veggies and freeze them. So that's a good way to save some money. And repurpose leftovers. All right, next slide. Absolutely.
Can you add spices to your food, like turmeric?
Yeah.
Ginger,
Yeah.
do teas to help with your cancer or keeping your body from inflammation?
Yeah, absolutely. The only seasonings I don't recommend to people are the ones that are pre-made, like Old Bay or seasoned salt, because it usually is very high in sodium. But the actual seasonings on their own, turmeric, black pepper, even the powders like garlic powder, onion powder, those are all excellent. And turmeric is very anti-inflammatory, as you pointed out. Go ahead. Any other questions?
I just wanted to know, for anti-inflammatory purposes, what are some foods to not eat as often? Because
Yes.
a lot of times neuropathy, inflammation.
Really, those processed and fast foods, they have so many preservatives in them, they're high in calories, and they usually don't have very nutritious ingredients. So those are the ones you want to avoid. Also, red meat and alcohol. And there's been lots of different things in the literature. A lot of old literature says that a glass of red wine can be helpful for your heart health, but now there's a lot of research saying that any amount of alcohol is toxic to the body. So I'll let you all do with that information as you will. Any other questions while we're waiting for this last slide? Go ahead.
When you're talking about red meat, what about the stuff that's like 90% lean beef or that? Does that qualify as lean meat or not really?
You know, Dr. Tuxson, you might be able to collaborate with me on this. Everything that I've read about lean meat is usually linked with colorectal cancer, although eating too much of it can elevate your risk for any kind of cancer. But I'm not sure if 90% lean meat impacts.
Yeah, the key point I think you raised is a good thing about lean versus so-called non-lean is the fat content. And so the lower the fat content, the better off you are for many things. So if there's a choice between lean versus not, get the lean. Now, the problem is sometimes that tends to be a little more expensive. The other thing, though, surprisingly, a real lean piece of meat, take a filet mignon. What's the first thing you do to give it flavor? You wrap it in bacon. So the fat does add. A well-marbled piece of meat tends to have more flavor than that piece of meat does not. So that's an issue you get into. Then the third thing is how do you cook the thing? I think that's an important point, which I'll leave to you.
I agree, because I know grilling and charbroiling, those are all linked with cancer as well, right? So how you prepare your meat is important too. Okay, so finally we came to, go ahead, please. Air frying, we don't have enough research on it yet. We just don't know yet, so I can't give you an answer.
But I will tell you this, air frying like the George Foreman grill, less fat. So that by not frying, because maybe you're not adding all that extra fat, adding extra calories, adding extra, so it's better than just plain old frying. And
Sure, one more before I finish up.
Is a cast iron skillet not good to use?
I've actually heard that it is really beneficial, especially if you're anemic. But it's the actual burning of the meat and the chemicals within boiling and grilling that is linked with cancer. Okay, so we have our last slide here, guys. Thank you for being patient with me. So here we just have some practical examples of how to have an anti-cancerous plate. So again, we have our antioxidants. We have our lean proteins, such as salmon, mackerel, all those things that are known to be anti-cancerous, cruciferous vegetables, and water. So here's one example of how to do your plate, but I highly recommend, because this is page 20 and 21 in your book, putting it on your fridge and figuring out some different ways that you can customize it to have an anti-cancerous plate. Some other tips for simple swaps. Whenever you're trying to make large changes in your diet, because I'm sure not everyone's plate looks like this every single time, it's always a great idea to start with dinner. You're at home, you can prepare things to your liking, you're not in a rush trying to get out for work, and getting breakfast or lunch. So I recommend starting with that. Remember moderation for your carbs, not elimination. The brain needs carbs to think, but cancer also prefers it. So we really want to moderate with them. So cut back on rice, pasta, sweets, as well as sugary beverages, which I don't think we mentioned earlier, your juices, your sodas, etc. Routinely add anti-cancerous foods to your grocery store list. And of course, you want to add green and yellow fruits or berries as snacks and side items for your meals. And that's everything I have for you guys. I think we're at time. No, we're not at time.
No, you're not out of time.
Okay.
But we can take a new direction. Have you sit up there. We're going to bring all of our speakers. Where you going? Sit back down. Oh, okay. Oh, the old excuse. Thank you for coming on out. I appreciate it. We're going to bring all of our speakers back. Thank you very much for coming out. And thank you all for being here. Now, Stan's going to take a microphone on that side. I'm going to be on this side. If you have a question, please raise your hand. But I want to get a few things started off. On that side, Stan. Like I said, he's a former Georgia state legislator. So if you want to know what happened to Georgia, there you go. So now, okay. I want to, if I can start with you, Ursula, for a second, and you and Dr. Sano can help me. So, where do you go to get this screening? Who determines where I go and when I go to get it?
We got another answer over here as well.
You should actually start with your primary care physician.
Most of your screenings, like I said, should be quarterbacked through your primary care physician, but you should be able to ask any provider that you see, how can you get a lung cancer screen? And in various areas, there's various programs, there's various initiatives, there's various screening centers, but start with your primary care physician. If you see a specialist, you see an oncologist, a hematologist, a pulmonologist, for what other reasons that you see them, you can ask any of them for a referral or recommendation as to how you can get a lung cancer screening.
So Dr. Fano, go through it again for us, please. Who are those people who absolutely should get screening for lung cancer?
So the current criteria is if you are between the ages of 50 and 80, if you have smoked any time within the past 15 years, and that's expected to change to ever smoked, but within the past 15 years, and if you smoked more than 20 pack years, which is 1 pack a day for 20 years, 2 packs a day for 10 years, along those lines, then you should talk with your primary care physician about getting screened.
Before I ask these folks from Heartland, because they do imaging in a different way than what other folks do, tell us the difference between that person from primary, secondary, and tertiary smoking. Okay. What is the difference, and does that factor into getting screened?
Yeah. So primary smoking exposure, that's the person actually doing the smoking. Okay, and then the secondhand smoke or secondhand smoking, that's the person that's inhaling sort of the secondary. So they're exposed, but they're not actually doing the smoking. And the tertiary is what we're finding out is that the smoke and the byproducts, they get into clothing, they get into carpets, whatever else, and people that get exposed to that are also getting some of the bad products there that they're getting third hand from. The criteria right now is really only set for the primary smokers. Okay, keep in mind if we look at all the types of screening, whether it's prostate, breast, lung, GI, that lung is the new one on the block. And we've already seen that some of the criteria has already changed because as we learn more, we're learning that one-size screening doesn't fit all people. And so they're making adjustments there. And later we might find that there might be other risk factors we can quantitate. If you're a secondhand smoker exposed to this much, but we're not at that point yet. But these types of discussions still need to occur with your primary care physician, and then they can kind of see what steps need to be taken secondary.
Now, both you and Ms. Mathis are affiliated with facilities. These folks from Heartland Imaging are standalone. So what is the difference from getting a lung CT for screening for cancer at a standalone facility versus getting it at the hospital? Is it the same test?
So it's the, what? Oh, my bad. So it's the same, the low-dose CT lung screening is going to be the same whether you go, it doesn't matter which facility you go to. The difference between us and the hospitals is we are completely outpatient, so we're going to be at a lower cost. We're going to get you in quicker than the hospital. We're going to give you a more like patient-focused care where it's more personable. And we're also able to work with your providers to send them the results, send them the imaging. And then something that I'm working on with my pulmonologist right now is if you do get your CT low-dose lung screening and then you find that if like your provider finds something like some nodules, we now have the ability to do the protocol for the ion CT for them to do the 3D lung mapping for the bronchioscopic procedure. So we can power share those images to the providers.
So thank you very much. We appreciate
and also,
it.
you mentioned the prostate earlier. We can do those as well at Shelbyville Road.
Well, I appreciate that. So a couple of things that were said right there, which were rather interesting, in which I want to come back to Ms. Mathis now. So when the CT scan is done and a nodule is found, so what? What do we do now?
So once you have the results of the CT scan, again, you return to your primary care physician or the ordering physician, whomever order it, and a nodule is found. Further testing, biopsies, diagnoses are needed to determine what that nodule is. They do a comparison of prior scans, more further workup. Once the nodule has been found, in our area, we have a nodule clinic. So we send you to the nodule clinic. Some of them are benign, some of them we have to biopsy, some of them we can't reach with surgery. So it depends on the individual, the nodule, as the course of action that we take. But we do then put you in the navigation service so we can help navigate that process.
Before I come to you, Stan, so Dr. Flano, so I have this nodule, and you guys have talked about it being benign, non-cancerous, or possible cancer. The only way you're going to find out is to take a sample and give it to the pathologist to look at. So how do you get this biopsy done? Is it done, you got to crack somebody's chest open to get it? Do you take a needle and go through the chest? Or are you doing something through, a bronchoscope, I guess, and going down into the lung?
So yeah, and actually, it's myself and I have a nurse practitioner, and we actually run our lung nodule clinic, so we get the referrals, we see this quite a bit. We have different calculators, assessments, reviews of scans to decide the likelihood of what we're looking at. Do you think it's benign, or do we think it's cancer? Should it get a follow-up, or shall we just move to biopsy or surgery? So if we see something that it looks extremely high risk of being cancer, and that's the only place we see it, then we kind of move towards trying to get them to surgery quicker, rather than going through a biopsy and proving what the predictive model already shows that it is cancer. Just get it out. We'll diagnose it and treat it at the same time. If it looks like there might be more involved, there might be some lymph nodes, or we're not really sure, we're somewhere in that intermediate range of it being cancer, then we'll pursue a biopsy. Biopsy could be using a little camera scope. We can go into the lungs and guide our way there through different systems and take samples. Or we could ask some of the radiologists, if it's very close, to come with a needle from the outside and watch on a CT scan as they go right into it and get samples and come out. And then we can make a determination. If it's a low risk for being cancer, maybe someone had a scar tissue infection or whatever else, then we may sit back and say, well, we'll watch this a little while and see what happens. If it stays the same over a certain period of time, 2-3 years, okay, we'll just leave that alone. If it looks like it is growing or changing, then we may have to do something a little more aggressive.
Okay. Just before you come with this next question, our dietitian painted a very good picture about the plate, colorful and those kind of things. So the cancer patient already said that we needed some kind of nutritional guidelines. And this is for you and Ms. Mathis. So now I'm in a food desert, and that colorful plate is hard to get. And you're telling me that I need fruits and vegetables and those things, antioxidants, all that. As a dietitian and now as a navigator, how do you help a patient that has a food desert? There's no stores around in my neighborhood, and how can my church help me? What do I do?
So, I am live. Okay, it's a great question. I always like to ask patients where they are getting their groceries at, what's available to them, what they like eating, and I go from there. Although that plate, like you mentioned, it is colorful and it does have some expensive items on there, even if it's canned tuna and you have to get some frozen berries or some freeze-dried berries, there are other ways to get at the recommendations. So I would always start with questions and see what's accessible to them.
All right, but not to let you off the hook that quick, though.
Sure.
So we go into the store, and we see these canned gross foods, and here in Kroger, which national chain, sometimes you go in there, they got 10 cans for $10.
Sure.
Heavy syrup, light syrup, salt, not salt,
Yeah.
in water, not with water. Then you have frozen, and then you have fresh. So which one am I supposed to buy?
Yes.
Which one is the best for me?
Yes.
And is one deleterious for me?
Yeah, so fresh is always best because it's going to have the highest amount of minerals, vitamins, et cetera, in there. So fresh is always best if you can buy it. If you can't, frozen is ideal. But canned is okay too, and you can buy it in water. If it comes in oil or it has a lot of sodium, you can wash it off a lot of the items. But it's better to have the nutritious food than not to have the nutritious food.
One other thing. All right, she's going to answer me. I'm going to hold on. Okay, raise your hand. How many of y'all eat greens? Come on, raise your hand. All right, the average time that you're cooking greens, how long is it? Tell me, how long are you cooking your greens?
Let me ask somebody that really knows right here.
Yeah, come on, how long are you cooking?
Not as long as I used to.
Not as long as you. Well, come on, how long are you cooking your greens? How long? 45 minutes. How long you, sir? 4 hours. So we got 45 minutes, 4 hours. What about you, ma'am? You raise your hand. Who else? Greens, come on, going once. Huh? We got 5 minutes. So we have people that eat greens that are still alive. We have people that eat green when they're nearly dead. And we have a guy here who's eating greens. He's done killed them, buried them, cremated them, calling it a day.
It's not
4
true.
hours.
Not
So
true. Come on, 4 hours of cooking
The
greens? Go ahead.
secret,
Tell me
the
the
secret
truth
with
now.
vegetables, especially if you're
Slow
cooking them
cooked.
in a liquid, is drink the juice.
I'm sorry,
If
go
you
ahead.
drink the juice, you still got the vitamins and the minerals. If you don't, you're throwing it out.
Say that again for me, please.
So it doesn't matter how long you cook it, as long as you drink the
Okay,
juice.
but am I cooking these greens with fat back, with salt?
No.
Or am I putting something else? 'Cause
We're
you
not
want
going to
me-
ignore what we already went over.
Uh-huh. All right,
We're
so
going to try to do
we got fat
lean
back here?
meats. You can
Hold on,
try
we got
turkey
fat back over
leg.
here. Uh-huh, go ahead.
I said we're not going to forget what we already went over, right? So we want to do lean meats, but you can do a
Say
turkey
turkey or
leg.
ham.
And that's a great option to put in your greens instead of fat back.
Okay. Yeah, so smoked turkey greens. So
Yeah.
You said, I'm sorry, go ahead, Ursula. I'm sorry, ma'am.
Yeah, I want Ms. Mathis to answer that. 'Cause
Yes.
Caregivers and support groups, I think, are real important for this audience in the food desert.
So this is interesting. In the food deserts, first of all, like I said, you have to be honest about your resources and what you have. And in most centers, there are some resources that are available, or there is some help, and you have to be within a center that engages the community, engages your faith-based organizations, engages the American Cancer Society, engages the other resources. No one fights alone, or no one can do it alone. There's not one institution that can serve all of their area. So everyone has to collaborate to be able to meet the needs of the patient. And everyone has a role to play. You know, in 1 Corinthians, it tells us that we created the body, and he created your ears and your eyes and all those components of the body, but the body doesn't function the same without one of them. So everyone has to collaborate to create this body to help and serve the population and the patients that we serve.
Back to the imaging and how you get your referral. The biggest thing that we push is, as a patient, you have the right to choose where you want to get your imaging done at. For example, if you're going to a big hospital and your provider orders you an MRI and it's going to be 2 months, you can say, hey, I want to go to this outpatient center that's going to be less expensive for me and get me in a lot quicker so I can find out where I want to go. Also, on the CT lung screenings for the low dose, if you have Medicare or Medicaid or in the qualifications of the age range and the smoking years, that is covered once a year for no out-of-pocket cost to you. So we actually have some low-dose CT lung screening order pads on our table that I'll leave with you guys. And if you all are in that qualification, you can take one of those order pads with you and hand it to your doctor and say, hey, am I covered to get, my CT lung screening?
That's a very good point to point out that screening in the state of Kentucky, in the Commonwealth of Kentucky, is a covered service. Breast, prostate, colorectal, and lung. These are all covered. And believe it or not, that's because of the Affordable Care Act, but Kentucky was one of the leading states as far as getting that stuff done even prior to the ACA. One of the things Kentucky is also a leader in is getting coverage from insurance companies on biomarkers. So could you tell us what biomarkers are, Dr. Fano, and what is their value in terms of our treatment?
So biomarkers are characteristics of the cancer, of lung cancer. It's any cancers, but specifically we're talking about lung now. Characteristics of the lung cancer that can be detected that will help the clinicians pick a treatment that will work a little bit better than just standard chemotherapy across the board. For example, I mentioned that cancer, there's a genetic mutation which makes it behave differently. The different behavior is grows faster and divides out of control, or it may develop its own blood supply so it can feed itself, or it has a mutation that allows it to attach to different organs of the body. We can find some of these either receptors or mutations that we can test for, and then find the treatment that will stop any of those three pathways, right? And so you got to think about if you have a cancer that's building its own blood supply, and you can figure out how to give a treatment that'll stop it from getting its own food supply, it'll die off. And a lot of these treatments they're newer, so they're a little more costly, but they actually have better survivals, and they have less side effects. So someone who has to go through chemotherapy and radiation and it's going to be very harsh on their body may not have the same type of side effects from that aspect. The concern is, especially African Americans, that they are less likely to get biomarker testing offered to them, which actually contributes to some of the disparities, because without the biomarker testing, you may not be able to, or if you don't have the testing, then they won't know which of the 35 plus new medications with better survivals are going to be able to be offered to you.
We have a question over here.
Just want to thank the panel. A lot of great information shared. Specifically, though, Ms. Ivy, we know water is the best thing for us. However, we see a lot of sweeteners out there, Sweet and Low, Splenda.
Mm-hmm.
Can you talk about, if you do want to add a sweetener, what's good for you?
Believe it or not, regular sugar, because all those sweeteners are linked with cancer. Okay, stevia is a little bit different. It's like a different type of sugar altogether. So, but your Sweet and Low and another one you mentioned, those are linked with cancer. So I'd say regular sugar or go without.
Yeah, what's fascinating when you look at some of these sugar substitutes, you can argue, well, are they better than sugar? In some cases, they may actually be, particularly for your diabetic patients. But on the other hand, if you get a raw sugar, tell me, I think that's better than some of the refined sugars. Is that not right?
Yeah, it has a little bit less processing, but it's not all that much better.
And the other thing to be surprised is that some of the sugar substitutes actually associated with increasing risk of diabetes because they're so sweet, they trick the pancreas into thinking that they're getting sugar and stimulate pancreatic function. So there are a couple of little interesting things about them. I think that you're absolutely correct. Do without it if you can. So therefore, having said that, which one is better for me? To have bottled water, diet soda, regular soda, or a can of beer?
Water.
Say beer.
I think it was on our plate too, water. Yeah, you want to stay hydrated, flush out those toxins, and then everything else, it usually has other stuff in there. It's never like a simple product, so water.
It doesn't depend on how your day's going, that can of beer?
Well, I think it's going to be a rough one for those of us in Kentucky because, Kentucky's going down there to kick some Texas behind down there in Austin. Texas fan. Okay, I want our panel, if you have a question? Oh, I got a question. Okay, hold on a second.
This is more or less a Medicare question, but it's pertaining to health, okay? I just started getting Medicare, okay? And I heard you say that your first screening, that Medicare covers that, correct? For your first testing.
Medicare, no, your screening is covered, any health policy that you're under. In the case of lung, it's 45 for colon cancer, 45 for breast, 45, and actually for prostate, it's 45 also. So all those are free.
Okay, now what happens if you are, God forbid, that you're diagnosed with a small cell or something like that? Is that covered if you have to go through treatments and so forth? Something that I really would like to know since I am a prostate cancer survivor.
Yes. So those diseases are covered. So the screening, once a year, because that's what the recommended for the lung cancer screening is once a year. Now, if they see something and say you don't even they haven't made the diagnosis, they don't think a biopsy is needed, but a next scan is required in a shorter period of time, that would be ordered under a different category. So it wouldn't be counted as a screening, would be indicated for a abnormal finding. So you wouldn't have to worry about that because it's a specific cause, it should be covered from there. And then the treatment, if you are diagnosed with it, you should be covered under Medicare for lung cancer treatment.
Dr. Tuxton.
So let me say this about pairs. Pairs rule the world, okay? And another reason why I always try to tell my patients to advocate and ask questions is because there are a lot of biosimilars on the market, there are a lot of generic drugs, there are a lot of alternative drugs, and sometimes when your regimen is created and we've educated you and discussed one thing, when we submit it to be pre-certified by your insurers, Medicare, Medicaid, private insurance, it doesn't matter, we have to get them certified. They say that we're going to give them this for this diagnosis. They may come back and say, we pay for this. So then we have to re-educate the patient, okay, this was prescribed, this is an equivalent drug, or this is generic of this drug, or this is whatever it is, and this is your preference. This is what your insurance is going to pay for, and this is, if you don't choose to go with the insurance and want to go with the regimen, this is what your out-of-pocket expense would be. But those conversations really need to be candid with patients so that when you receive the bill, you don't think that your insurance just did not pay for it. But they do tell us under national guidelines what we can and cannot use. And
House
it's
Bill
going to
one-
be whether you come here, go there, or go here. They're going to pay for the same medication, or they're not going to pay for the same medication.
That's a very good point. And we were talking about biomarker testing. That particular bill in Kentucky was House Bill 180, and it pays for, it's paid for by the private insurance, the Blues, Aetna, but also Medicare and Medicaid as well. So that House bill was enacted in January of 2023, and it covers all the payers here in the state of Kentucky.
We have a question back here. Go ahead, sir.
Doctor, I'm so glad you touched on hookah, because that is not a topic I often hear about. I am a 2-time lung cancer survivor from 2014 and 2016 who advocated for himself, who's been in the medical field for probably over 25 years. But I'm so glad you touched on the hookah that I don't often hear about, but it's definitely one of the risks out there that younger people use hookah and vaping and those risks associated.
He's a ringer because he's also on the board for the Kentucky Lung Cancer. So,
Thank you. Thank you. Yeah, spread the word.
and was at our program in Frankfurt. Go ahead.
Yes, and yeah, spread the word. And it's very interesting. Each state sort of has their laws on, you know, age limits and things. Some of the newer products kind of escape some of the limitations on fines for when minors are involved with using tobacco products or tobacco-related products. And the vape pens are one of them, and the hookah bars are another, because people kind of just slide in, IDs aren't checked all the time. We know that in Georgia, a minor gets sold a tobacco product, fine maybe $250, right? Well, for all the ones that get away with, it completely outdoes. And we need to start thinking about how legislation handles some of these, how people are licensed, and how they're being regulated.
We have a follow-up on that.
Just also, I would like to hear more touched on is for patients or the communities not to go to Google, because we all know that the information is not always accurate. That so many patients, from my experience, have always gone to.
So we have Dr. Google and Nurse Bing, and a lot of people refer to that. The challenges with that is, you know, there's a lot of misinformation. Sometimes you'll come across something that's very accurate or point you in the right direction, and then other times you'll either have something that's completely wrong, or it might be from one person's perspective that doesn't apply to everybody. And so, you know, getting a little education from reliable sources on the internet, I think, is useful. But I still think it's important to discuss your specific situation, because not everybody's situation is the same. With your primary care physician, you can tell them, maybe I've seen something like this, but I wouldn't on the internet, but I wouldn't act on it to having a conversation with somebody who can tell you whether or not it's going to be useful, that information is useful or accurate or not.
Or you can summarize by saying, I don't think my 4 years of medical school is equal to your 1 hour Google search. We have one final question, then we're going to come back for each one of you to give us a take-home point and a call to action for each.
Oh, okay. Well, she answered the question, but this is something else. So my doctor has scheduled me for a CT scan of my abdomen. So do I need to advocate for that lung cancer screening? Because my history with my dad, I mean, he did pass away with lung cancer. So would that CT scan also cover all the things that need to be covered?
So the CT scan of your abdomen may catch the lower parts of your lung, Okay. To have them, and I don't know everything specifically. A lot of times we do find abnormal findings in what we call incidental findings on somebody that's having a scan for something else. Now, finding an indication for them to scan through your lungs, if you don't meet the recommended criteria, that would come from a discussion with your primary care physician. And I don't know the specifics. You know, if there's a strong, if your father were exposed to asbestos, or if he never smoked and had lung cancer, strong family histories, they might find another way or another route for screening through that. I think the criteria for a screening agency to remain credible through the ACR or screening regulation, if they start screening people who don't qualify outside of 10%, if 10% of the scans are somebody that didn't qualify, they're going to have challenge in maintaining their accreditation. So, but there's other reason to get scans of the lung if you have the indications for them to look.
All right, Ms. Mathis said a couple things that were important. Talked about family history. She said that at least 5 times. How many of you know the family history of whatever it is that causes people to die in your family? Whether there's diabetes, heart disease, a couple of hands. All right. So I think there's a holiday coming up, in which I'm sure Ms. Ivy's going to tell us about what food we should be eating at that. But this is a good opportunity, I would think, and I'll let Ms. Mathis comment on that when she gives her final marks, about a good time to find out. Pull out that checklist and say, what did Uncle Henry or Aunt Mary, from what did they die, or what diseases were they treated for? All right, Ms. Ivy, we got Thanksgiving coming up.
Well,
Go ahead and spoil it. Go ahead and spoil it for me.
No, the good thing is turkey is lean, right? So we're already a leg up with that. Focus on your side items. Like I said, we all love carbs. No one's saying get rid of them, but just moderate them. So when you have the mashed potatoes or the stuffing or the cranberry sauce, just factor that all in. Are we ready for the tips already? Can I throw my? Okay, so my last tip would be that, we all eat. Cancer eats too. So eat more protective foods, those yellow and green produce, your cruciferous vegetables, your berries, versus the riskier foods that increase our risk for cancer, like the red meat and the fried foods and the alcohol. And y'all have a great Thanksgiving.
Thank you. Ms. Mathis.
I think my takeaway is self-advocacy. I don't think there is, like Dr. Fanal said, when we do our research, Google is okay, but do credible research, credible sources, credible, Wikipedia is not that credible. So go to national guidelines or national standards, or what you put in your toolbar matters for as what national benchmarks you meet. If you know of a reputable cancer center that you want to ask that question, go to their site, but use your tools wisely so that you can advocate for yourself and to educate yourself, and know that your journey is personalized. It is your journey. As I navigate and I see people, I like to deal with real lives and real situations, so I never say the do's, don't. What you do in moderation. Control your habits. Don't let your habits control you. Every now and then you want some pork, but you can't eat pork every day. Every now and then we're going to overcook our greens and they're not going to have any juices left in it that we can drink. But we know the majority of the time we're not going to be able to cook them like that, So it's not what you do, it's the frequency of you doing it. And when you start to live better and educate yourself and to ask questions, you feel better, but then you have something that's called a conscience that kicks in every time you do the opposite. So it reminds you that you shouldn't be, or I'm going to do it, but I'm not going all in like I normally do. I'm a social drinker, but when I drink, I know the next day I got to double up on my water because I got to flush this out of my system. But I'm not going to drink today and drink nothing but sodas and iced tea tomorrow, and I done went 3 days without water. That's self-destruction. So advocate for yourselves. Come to the table knowing everything about you, your healthcare journey, what you like, what you don't like, your do's, your don't, what your habits are, and what you need to do for yourself to assist your caretakers into providing optimal care for you.
Dr. Flynn.
I truly believe that, a lot of these disparities, these differences between different socioeconomics, races, whatever, like I said, it's multifactorial, but we can never get ahead of these if we can't get health equity until we have health literacy. And without that literacy, without getting that knowledge, we're never going to achieve it. I'm hoping that we got a little bit of some idea of directions to go, whether it is the prevention, whether it is the screening for risk factors, whether it is what happens with the treatment to move forward. So now that you have the knowledge, is to go out and to act on it. And not just for yourself, but for those around you, the loved ones around you, and especially the children, because prevention, if we can get enough prevention, we won't have to worry about these other aspects of it later.
Well, I hope that we have met your goals that we talked about at the beginning. I want to thank our panelists. Please give them a hand. There is lunch that is provided, and you'll have a chance to ask more questions of our panelists and also the rest of us at that time. Please fill out the post survey, and then you'll be able to turn it in when we go back to the where the lunch is. The last thing standing between us and the aforementioned lunch is Deacon Stanley Watson's closing prayer. So please don't think less of me, but I sure hope it's a short one. Stan, please.
Let's give Dr. Tuxton a hand. We'd like to thank the pastor, and we'd like to thank the Burnett Baptist Church family for having Hill Collaborative here today. And we hope that something was said or done that will tickle your fancy, but also open up the windows of your eyes. We also want to thank Amgen for being our sponsor and being with us here today as well. Don't forget, we'll have a second part on Saturday. On Saturday. So everybody say Saturday. So invite somebody to come on this Saturday so we can conclude the second part of our presentation so that we can educate, as Dr. Flano has said, our community. Let's go to God in prayer for our closing prayer. Lord, we first want to thank you for our ceremony and our proclamation today as we presented this information to these people. We ask God now that you will bless the food, we bless the hands that have prepared it, and we ask God to be for the nourishment of our bodies. Now unto him who is able to keep us from falling and present us faultless before his presence with exceeding great joy, to the only wise God, our Savior, be glory, majesty, dominion, and power. It is in his name that we pray. And the church said, amen.